We know actually surprisingly little about pre-cancer or potentially malignant lesions. We know a few things. We know that smoking and alcohol is bad for you. We now know in the new world that HPV is creating a new type of oral cancer. Across the world, just remember, it's one of the most common cancers that we have. And we know something, thanks to a lot of work in Asia, about some of the conditions that predispose to cancer, and this is beetle chewing, which is a very common habit in Southeast Asia in particular. It's actually rather difficult to see and know that you've got pre-cancer, and that's one of the major difficulties. Here's a lip with pre-cancer, but most of you wouldn't actually recognise that. On the next slide, somebody who smokes who's got candida, again, pre-cancer or potentially malignant disease, but not something that you might necessarily associate with cancer. And here, this very vague whiteness inside a cheek, pre-cancer, but it might not be. It could just be cheek biting. How do we know the difference? Well, we don't. It's actually very difficult, even for very experienced clinicians sometimes, to distinguish between those. And then you've got the problem of this massive field change. And here's one example which is quite easy to see, but any bit of that might at any time become malignant, and our job is made incredibly difficult to survey these patients and know which bit is going to go malignant. Molecular biology is an area of research which may help us in the future, but it's not there yet. And if you look at this, for example, here you've got two bits of different pathology that are both caused by smoking. On the left-hand side, you've got the keratosis just from the heat of smoking, which is entirely innocent. But on the other side, you've got erythroleukoplakia, which is actually potentially malignant. Spotting the difference between the two, even for experienced clinicians, can be quite difficult. There are lots of other stains that are available to try and identify precancers at the early stage. The trouble is, none of them are very good. They're either not very specific or not very sensitive, or they're oversensitive. So it's a very difficult field indeed. The answer to many of these questions lies in collaboration and cooperation, creating big data sets. And I'll just use a couple of examples of where big data sets can actually get you answers to questions very quickly. The obvious one is in joint replacements. The National Joint Registry in this country collects data on all joints and their outcomes, and as a consequence of that, we're able to identify without any costly, expensive and long-term clinical trials that a particular hip, the Dupuy hip, was actually failing. So that's the power of big data sets. For cardiac surgery, mortality is actually useful. It's not useful for many other things in terms of measuring outcomes, but through that data set, they've contributed to improvement in the quality of care of cancer. So NFORC has the opportunity in the UK and I hope across Europe to actually start to collect big data sets so we can answer some of the very simple questions that sadly even today we don't have the answers to. So it's a very important initiative and I'm very glad to see so many people have come here to support it today.
This is absolutely brilliant, creating the world's first ever research centre dedicated to this most socially sensitive part of our body, which will collect major data and organise research to improve patient treatment worldwide. Well done, Saving Faces.